Okay, it's 5:30, Tuesday, November 11th. I'll call to order the Finance and Personnel Committee meeting, I guess. Roll call.
Todd Spaeth,
Here.
John,
Here.
Emma,
Here.
Todd Kirking will not be here, and Tanya. Here.
All right, first period for public comment.
We have a couple people online. If anybody want to make public comment, they can do so at this time. I think you're good, Todd.
Okay, agenda item number 3 is approval of the committee minutes from October 28th, 2025.
I move approval.
Okay, I second it then. That's right. Okay, we got a motion and a second. I forgot about that. Yeah. Got a motion and a second then. Okay. Discussion with possible action on health insurance options.
Need to take the vote yet?
Oh, okay. Yeah, all in favor?
Aye.
Aye.
Aye. Okay, motion passes. Discussion with possible action on health insurance options for 2026.
Do you want to cue it up, Lori?
Sure. Well, we have our representatives here, Jax and Kyle from the Insurance Center, to discuss our options for health insurance. I know we got options from courts for the renewal, and I don't know if you had anything more, but if you guys wanted to go through what you found out for the committee.
Absolutely. So for those of you who are here, we have a handout, but it's not what I'm going to be sharing on the screen. The spreadsheet is just really difficult to work through when it's printed off. It's just a terrible size font. We can certainly take some of this information off after today to make it easier to read through, but we felt that the information that was in here was all relevant, and to take it off when you print, a spreadsheet with more than 3 columns on it, the numbers just get to be too tiny anyways. So we're going to share a spreadsheet on the screen. The summary that you have if you're here, we can send that out too. This just kind of walks through, and we'll touch on this after we go through the spreadsheet. All right, so here's who we actually went out to market with and quoted. So we quoted with Courts, obviously that's your renewal. United Healthcare did give us an offer. We quoted with Anthem. They were declined to quote. Sana is a level funded carrier. Allstate is level funded, and then 90 Degrees is level funded. We are still waiting on an answer from 90 Degrees. DTQ means declined to quote, so they just didn't provide us a number.
Page. You're on page right here.
I just don't know why this doesn't look like that.
90. Oh, you're in landscape mode, so your screen is extended, or your computer just synced a little bit.
Thinking, yeah.
Yeah.
All right, well, that's fun.
Okay.
Okay, we're back there. All right, I think we're good. So just to give you a heads up on this one, I want to highlight 90 Degrees. They've traditionally been the lowest in the market right now. Level funded means you would pay your premiums like you pay on a fully insured plan. You just pay 1/12 of the total for the year. Premiums don't change throughout the year. They did tell me today that they're expecting to have the offer very soon, but they didn't have it to us today yet. So they're not included. If we were to get a really good number from them and the committee's already decided we're working with Courts, we would just go back to Courts with that number and say that we are considering leaving Courts and try to get a better number from them. That's kind of the way the game works. Unfortunately, as insurance companies will only give you as good of an offer as they think they need to. They never give you their best offer, at least at first, or if they don't know a reason that they need to come down with what they have. One of the problems we ran into with Courts in the large group space is they give us literally no reporting. Like they might give us a loss ratio for the year, but they don't tell us what those claims were spent on, how people are actually doctoring. They hold the data, they have the control. And so when you're with them, it is hard to leave to find other carriers that are competitive. Once you do leave them and you get into a place where you have claims data, you're in a position of choice for the permanent future. So in the long term, as we work together, I would love to get you with a plan where you do get some data It's not going to tell you like which employee went to the doctor, what they talked about. It's not that specific. But I would feel much more comfortable when we do our renewals if we actually had real data to go to the insurance companies and say, hey, look, this is what was spent, not this number that we may or may not think is true actually. The other reality is courts will share a report over running 12 months. We don't know how many of those claims were last year, this year, because they issue your renewal prior to the date of it actually being renewed. So there is a chance it could come down still from what we're seeing here. Once we get the 90 degrees offer, I understand you guys want to make a decision pretty quickly here so we can move forward. So I understand whatever decision is made, but if that number comes in and it's crazy good, we want to make sure we at least get it in front of you, and then you can decide if it is worth another meeting or not. So of the two carriers that we did get proposals from, again, it was Quartz and United Healthcare. Quartz is your incumbent. The renewal, if you stay with them, this is your current pricing. This enrollment was accurate as of a month and a half ago. Enrollment changes throughout the year. So when we look at annualized budget, it's kind of tough to know exactly what that number is going to be, because when you hire people, you don't know if they're going to be a family coming on your plan or an employee on the plan. So when we look at this, we really look at those per employee pricing to figure out where rates are going to be when you're budgeting for the year. But we do have annualized totals, so you can see if enrollment stayed the same for the entire 12 months, what your cost would end up being at that point. And really, that's the only way to compare it, right? We have no way of knowing for sure what your enrollment's going to be throughout the year, but we know what it will be per person when they come on the plan or come off.
Is that the one that we got this originally one? Is that what it, oh, it's,
Correct.
okay.
Yep.
Because I'm not looking at it on an annualized basis. I'm looking at it per carrier. So it's hard for me to look at this in this kind of a format because that's not how I have it figured out. So I usually look at it what we have currently and then look at, per each, how they have it split out like this. So
Yep. That's in
looking
here.
at this is kind of hard to know that this is the same.
Yeah, I mean, that's all in here. So you can see
Okay.
the per employee price is listed, employee only is here, employee spouse.
Yeah, I was looking on this one, so I just,
Yeah. Yeah. So we tried to take their 34 pages and condense it to 2 or 3 instead of that giant document. And there was a revision since you saw that one with more plans, which you'll see in here too. So if we stay with Quartz, this is with what your enrollment was. So you do have 2 plans right now. They're the same plan design. One is the point of service network. That's the difference here. POS means point of service. With that plan, you can doctor anywhere outside of the Quartz network, and Quartz will pay them what they would have paid an in-network provider. The challenge is that sounds really good with Mayo, but if we polled these 3 people that are on this plan, they probably haven't had the best experience with those claims at Mayo. Preventative care isn't covered when you go to that facility, so that's a shock to people. Preventative care is only covered in network. And then you see the out-of-pocket is much higher if they go to an out-of-network facility. And they're subject to balance billing potentially. So if Quartz pays Mayo, they only pay what they would pay their own facility. And Mayo charges a higher price for their care. So those employees are subject to a balance bill when that situation comes up. So it's not a perfect situation. And if we move forward with Quartz and we keep both networks, we're going to do a really good job of educating your people on the reality of how that plan does or doesn't work. I think a lot of people buy it because they hear the first part of what I said, that you can go anywhere. They don't always hear the next part of it. And I don't think a lot of agents actually get into the nitty gritty of how that works in reality when you go. And oftentimes people buy it not knowing what they bought. They go in and all of a sudden it's not what they expected it to be. So again, it's really on paper, they're the same plan. It's just the network choice. And there is a premium load for being able to have that secondary network, right? Or that out of network benefit. So even though these are the same design, you can see there's a significant price difference between the two because of the ability to go out of network. It's also very hard for us to predict who will make a change to that. In theory, we could have everybody bought this plan last year for the first time and is frustrated and now they want to go back to here, but we can't assume that. So we're building this projection based on people staying with their same network choice that they have today. Does that make sense?
Kyle, with people that do select that that second option, like what percentage of people actually end up selecting I can't see the top of it, of the spreadsheet of what it's called, but
POS, point of service. So
Mhm.
it's usually really, really low.
Yeah.
Initially, like the first year we offer it, we see like almost a third of people take it because they like the idea of Mayo, but that quickly drops down once people actually end up using it. It's pretty rare that someone chooses that plan and then stays on it indefinitely.
Yeah. So it's an education piece is important.
Yes, absolutely. And I don't want to take that away because if, you know, that's the reason they're here is like, it's the one place they can have both access points. Like, I don't want you to lose a good employee because we're taking that away. But I wanted to really call out that difference because one of the proposals I have for you would eliminate that difference altogether. And that may be worth doing.
Lori, if I remember right, in the past, we've had people on the POS plan because like somebody lived in Reed's, like somebody lived far away and was driving in and they wanted to keep their health care in their home area. Is that still
That's not the
true?
case. It's the case that they don't want to lose their doctors.
Okay.
That's
all
why
right.
they're using that.
You might have people that thought that they needed it for that choice, right? And that's why the education is really important because courts, pretty much anywhere that anyone who's going to be working here, they're going to have great access from courts. It's just not Mayo. Like I deal with Richland County as well. Courts is the best network for them. They're with the ETF, so people get weird choices, and unfortunately, people end up choosing a plan that's not that a lot of times. But courts is the most broad network, with the exception of Mayo in the area. So, I mean, if you hired somebody that was remote, I could see the POS being necessary for someone out of the area. But here it would just be if they want that Mayo access.
I think part of it was too is that they had somebody who was out of the house but still under the plan, so what, younger than 26, that was away at college.
So they may think they need that because of that, but courts does have out of area dependent coverage, so they wouldn't need to have that either. But again, that's just having the right person for them to go to and ask those questions, right? If they ask the question, they don't get a good answer, or they don't know where to ask.
Yep.
I absolutely could see why they would make that choice. The reason I bring that up is, again, a lot of people pick that plan for reasons that aren't true, right? And the reality of needing it or paying for it maybe wasn't what they thought it was going to be. If we have a year where nobody takes that plan, we could potentially eliminate it, but you got to think about new hires too. And it does sound kind of catchy to a new hire that you can go anywhere. It's just frustrating sometimes in what happens when they do go. So that's your offering now. The first plan I want to show you is just your renewal. So if we stuck with courts and changed nothing, it's about a 12.5% increase is what we came up with. If you look at the courts renewal, it's confusing because they have two different numbers, because the point of service plan is going up at a different percentage than the HMO plan. So this would be with people enrolled in their current plans, what the total would be. So you see, you go from 35,000 a month to 40,000 a month in total.
Can you go up to the top for me, Kyle?
Mhm.
So this is a combination of what I'll refer to as the HMO 1 and the POS 1 plan.
Mhm.
Is there an opportunity to mix and match? Could you do like an HMO 1 and a POS 2?
Like pick different plan designs for the two, you mean?
Right, like in between the two, so you have right there, you've combined them to say HMO 1, 1 and POS, and then I'm kind of jumping ahead, but if you go to the right there, you have higher deductible plans and things like that. Do we have the opportunity to choose HMO for one and POS for the other?
Yes.
Okay.
Yep. And you can offer more than one plan of each too, which I'll get to in a
Okay,
second.
okay.
And I'll make
I'll
more
let you
sense.
do your thing. Yeah.
Yep. No, you're going that means I'm leading you the right
Right.
way. So this is if we do nothing. If we stay the same, this is what your cost will be. We would think we could get that number down if we get a competitive offer from somebody else.
Okay.
We don't really have that. I'm going to show you United Healthcare in a minute here, so you can see how competitive it is or isn't. But United Healthcare's number wasn't good enough for courts to make any changes to what they're offering us. So if we stay with courts, they will allow us with your enrollment to have 4 plans. Right. So what we could do is offer an alternative deductible or out of pocket at a lower price point. The reality is not everybody doctors the same, and it's great that you have a low deductible. The average deductible in Wisconsin is $3,300 right now. Yours is $1,500. The average out of pocket max in Wisconsin is just over $5,000. Yours is $3,000. So it's really good that you have a good plan. But of your 28 people that are enrolled, I bet at least half of them, if not less than that, if you want to argue with me, that's fine. But probably a third to half of your people don't hit their deductible or out of pocket. I would bet it's even greater than that. Our statistics say that it's less than 25% of people actually have more than $3,000 of medical expenses in a year. The ones that are over that usually go way over it, right? And then the rest of us are in the middle, and it's great that you have a low deductible, but if I only did $1,200 of testing, did that deductible really help me? Right. So most of our employers are now offering two plans. They offer a low deductible alongside of a high deductible. It allows you to have a lower price point for that higher deductible plan without taking away that low deductible offering from your people. And now they get a choice. Do I want to pay more to have a low deductible? Or do I,
Yeah, you just have to reshare. It looks like you overwhelmed Zoom with your spreadsheet. Okay.
it's probably how you all feel too.
Yeah. No.
So what I picked out was a 3,500 deductible. The reason I picked it is that's the lowest that you can do as an HSA and maintain HSA eligibility. To give you some benchmarking in the area, we work with Vernon County for their benefits. They have a 4,000 out-of-pocket max on their copay plan and a 4,250 out-of-pocket max on their higher deductible plan. So they've kept them very similar to each other, but by having a lower or a higher deductible and no copays, the premiums are still a lot lower. So by doing this, we could offer a competitive plan where in a worst case scenario, I know they're only going to pay $500 more out of pocket. That's not bad. But the premiums are going to be significantly less for that person, which in turn means the city of Viroqua is paying less for those people who choose that plan too. But we're not taking away the 1,500 deductible plan. We'd have a mutiny if we took that away overnight. This also allows us to see who of your people care about their deductible or not. You're going to find that typically we see about 35 to 40% of people will choose a lower deductible or higher deductible plan if it's a lower premium. Some of them are way greater than that. I'm not trying to oversell this. I want to give you low numbers. So what I did is I just picked out that as an option. They have a lot more higher deductible plans, but I don't want to go too extreme because then people will be afraid of it and not make the change. So if we do your traditional copay plan alongside of a 3,500 deductible plan, you can see those premiums are now lower than what you're currently paying, which obviously means they're quite a bit lower than the renewal as well. This plan is actually 11% below your renewal.
Where we're at currently.
Below your current, not your renewal. Correct. Which in the private sector, an employer would probably say, hey, we just got to offer that one. It's only 500 more out of pocket max for my people. That's a lot of money I'm going to save. We got to do it. Public sector, a little bit harder to make tough choices like that. And as selfishly as your new consultant you're working with, I don't want to be the agent that walks in and raises everybody deductible year one either. Right? They're not going to be happy with me. So this is a less aggressive way of getting savings without taking anything away from people. And you're going to find that you have people that right away are like, sweet, this is cheaper. I don't care about that out of pocket. They love that. And you're going to have some of your unhealthiest people that look at this and say, if it's only $500 more because I'm hitting my out-of-pocket max, but I can save that or more in premiums, even they will take that. So it's not hard to just conceptually think about why 40% of your people will probably change to the cheaper plan. I did a
sorry, it's just hard with the spreadsheet. Can you go back to the beginning of the spreadsheet?
This is why we don't print it, because it's too hard to go back and forth.
Yeah.
I can these in here for a second if you would like to see the 3,500 right next to the other plan, what the premiums used to be.
Sure.
Would you like to see that?
It'd be great. Yeah, it'd be great to see them side by side, flipping back and forth.
Might not have gone far enough. That's the furthest I can go on my screen. All right, so here's the premiums. Good, that all fits in your guys' screen. Here's the plan design, and then I'll scroll back down. So your out-of-pocket max now is 3,000. That's the most somebody could pay in a worst case scenario. Here it's 3,500. But how they get there will be very different. There's not going to be copays for doctor visits, prescriptions, and things like that.
And does either of them come with like an FSA option?
You could do a medical FSA with your current 1,500 deductible. If somebody chooses the 3,500 plan, they would only be eligible to do the limited FSA, which would be for non-medical, so dental, vision, and services like that. If they choose this plan, they can do an HSA contribution though. So they can put up to $4,400 next year into a health savings account if they want to. They don't have to. They can just take it because it's cheaper. But when you put money into an HSA, it's not like an FSA where you lose that money if you don't use it. right? FSAs are nice because you can flex your medical expenses and write them off, but if you don't use all that money, you lose it. When it's put into an HSA, if you don't use that money that year, you don't lose it, but it's still a tax deduction for the year. So there are a lot of really like people that really watch their money and where it's put that really take advantage of HSAs because it's the only place that you're allowed to put money tax-free. You can take it out that year or any other year tax-free. And then you can even invest the money if you have a lot of money in there, and then it grows tax-free. So it's triple tax-free. Any financial advisor, if you talk to them, would recommend that you do that. But the reality is, for some people, having copays for their prescriptions is more important. I don't want to take away that from people, but I want to try to save some money and find a way where we could get rates down. The other thing this would allow us to do is pay for the cost of neighborhood clinic, which is another thing I'm going to talk about shortly here.
I have a question.
Yep.
So what's the 3,500 versus 1,500 is the deductible?
Yep. So the deductible is what you have to pay before insurance starts paying for any diagnostic care.
Right. Yeah. No, that wasn't my question.
Yep.
I just was wanting, because I can't see what the
She can't see the
the
left.
name of the row is. So,
Oh,
and the
sorry.
and the 3 versus the
Yep. So
7,000
this is deductible.
And that's, oh, the
50
second one is family deductible.
Yep.
Okay.
So
that's-
every other one to figure out what you're trying to see there. 1,500 to 3,000.
so the deductible is going up 2,000,
25,
that-
yeah, 2,000
but the
out of pocket max.
out of pocket max is only going up 500 basically when you hit your deductible.
And
you
if
hit
someone
your
had a
max.
$20,000 colonoscopy, which is real, if you have a
Mhm.
colonoscopy and a lot of polyps and it's not preventative, they're $15,000 to $20,000 right now.
Mhm.
Even on that 1,500 deductible, I'm still gonna end up paying 3,000.
And the copays on the first column, you pay those no matter what, even after you've met your deductible, right?
Correct? But
Yeah.
not after the out-of-pocket max.
Right.
After you meet that, then they go away.
So it's one thing to say that it's changing, that it's affecting them only by a total of $500, but actually to change your deductible from 1,500 to 3,500 is actually a huge hit.
It's $2,000,
Yeah.
absolutely. Yeah,
So I
but
just-
in a worst case scenario, even on that 1,500 deductible
Mhm.
plan, they're still gonna pay $3,000. Like deductibles are what everybody looks at,
Mhm.
but the reality of how health insurance works anymore is it's one of the least important parts of the benefit.
The
Because-
deductible?
Yeah, because the cost of healthcare is so high.
Mhm.
Like $20,000 for a test now is nothing. People aren't just paying their deductibles anymore. They're either barely getting to their deductible or you're meeting that maximum out of pocket with the way doctoring is done now. But I agree with what you're saying. I would never want to come in here and go from a 1,500 to 3,500 as our only option. That would go over like a ton of bricks. That's why I wouldn't recommend we take away your 1,500 deductible. We just have this as a second option next to it. And I didn't want it to be a $5,000 or $7,000 deductible because that would be even crazier.
Mhm.
And that is the lowest we could go and still meet HSA rules. So if we went
Okay.
any lower than that, they wouldn't be able to fund their health savings accounts, which is something that a lot of people like to do.
Thank you.
Okay, we currently have a HRA.
Mhm.
Did you work on that at all with this plan as well? Because that's going to be a big difference
Yep.
between that and an HSA.
So you would not do the HRA with the HSA eligible plan. That would just be tied to the plan that it is tied to today.
Okay, I'm just thinking about how I'm going to administer this with two plans, an HRA and HSA, when I have to put all that information in. And it's becoming very complicated.
Mhm.
Just going to throw that out there for all of you.
Yep. So I'm not telling you have to do this, right? But this is the only way if you want to save money, right? If you don't want to pay $50,000 more next year, that's going to be your only way to do it that we've seen so far. Or raise everybody's deductibles and out of pockets to 3,500, which I don't want to be the person that comes in and does that to all your employees.
My other question is that come next week, we have to have open enrollment. And if we're not having all the numbers yet, I'm not sure. Can you guys even make that deadline?
Right now we could, if we want to wait and see if 90 degrees gives us a better number and then try to beat up courts, we can't make that deadline. But that's up to you guys.
Because we have to have it in November because we have to have it in payroll in December. That's why I'm a little nervous that we don't have all the numbers yet.
I get it. I wish we had them sooner, but it's just not the way it works, unfortunately. Like we have groups all the time that decide to make a decision before the time like is actually due because of just the practice of actually doing the benefit rollout is tough. But I can't make a carrier respond faster than they have the ability to. And right now, with rates being what they are, Quartz is going up 32% in La Crosse County this year. It's just every single carrier is busier than they've ever been. And what normally takes 2 weeks to hear back on is taking a month to 6 weeks now for numbers. It's just 90 degrees we're waiting on. So you can make a decision based on Quartz United Healthcare after today. If numbers come down, that's good, right? We just can't go back and ask for more money if numbers went up, and Quartz numbers are not going to go up.
You might have already,
we-
oh, sorry.
Go ahead, Emma.
You might have already said this, but with the, I don't know the name of it, but the essentially the one that has the Quartz renewal something. Sorry, let me try to see that better with my, the renewal alternative one.
Yep.
With the, does it cover just primary care, like annual visits, or are you still paying the full deductible?
Yeah, preventative would be covered.
Yeah, just, sorry, go on.
Preventative care is covered at 100% still.
Okay.
So if that's all they're doing it for, both plans cover it the same.
Okay.
Non-preventative stuff where they are going to notice a difference for sure.
So
Sorry.
I just have a
quick-
clarification. Go ahead.
Yeah, I was just gonna ask clarification too, is under, where it says under the HSA one, column O, you said 0% after deductible, assuming that part of what you said is that they're gonna reach their deductible faster because they're paying full price for everything to whatever is listed to the left. I don't know if you can scroll that way just a little bit as well, but all those items that currently there's just a copay are now going to be full price, so you're going to reach that deductible. So that's also really part of
That's a big deal.
that's a big deal, is that if you are
Yep.
Doctoring, right, is the word you use. If you're doctoring, maybe not have big items come up, but if you consistently have items that you have to go in and
Yep.
Whatever, you're going to be paying full price for those before insurance actually kicks in.
Absolutely. Yeah, if someone's going to the doctor frequently, they're going to want to stay in the copay plan for sure. Unless we take this savings and do the next thing I was going to talk about, and that would help remove that. I don't know where we're at for time, but
Yeah, we're okay for now. We do have counsel in 25
I-
minutes.
Just a
Time hit,
quick
but-
clarification. Are you saying if we offer the multiple plans, that is what gives us the savings? Okay, so
let me unhide now.
But if somebody takes, but to clarify Tanya's comment, if somebody takes an HMO, the HMO one plan, they're paying that rate under HMO, they're not getting the savings. It would be if everybody slid over to the HSA plan that you would get that 11% drop.
Not even, yes, if you had everybody, and
If
I'm
you had-
not saying that, right? We're not
Right.
gonna have everybody make that move. So I did a blend here of the two plans. Assuming 60% kept the copay plan and 40% went to the HSA. And this is a live formula, so I can type in any number you want to see and what that would do to the budget.
What cell are we looking at?
Down here
Yeah.
is your total. So you're at just over 30, just
Yeah.
under 36,000 right now monthly. If you do this two plan design, copay plan and an HSA plan, we do HMO and POS for both, so we're not taking that away from anybody. And we had 40% choose the HSA plan and 60% stay with the copay plan. This cost would be $40,000 less than the renewal with Quartz. And I can move this back and forth any way you want. If you think I'm wrong and it's 70% would stay, you still save $30,000 compared to the renewal.
Right. We're not gonna know until people enroll.
Correct. But we've done this a lot,
Yeah.
so I have a pretty good idea of what I think people are gonna move to. I'm not just making it up, right? I would say out of the 500 employers I work with, probably 470 of them have two plan or more plans.
Kyle, you mentioned something about the neighborhood family clinic. I'm somewhat familiar with this United plan because I had it at La Crosse County with the neighborhood family clinic.
Yep.
So, and I don't know what the cost is on that, but essentially when we were at La Crosse County, we could go, any office visit was covered 100% a neighborhood family clinic.
So that's an option, and that's something we talked about at our prior meeting when working with us. So The way Neighborhood Family Clinic works is it's a fee for service model. It's not a monthly membership. You only pay when people use it. And I have a route sheet here for those who are in the room, and I can switch my screen to sharing it if you want to pass those around, Jax. I suppose if we give you all of them. At Neighborhood Clinic, they charge typically about 20 cents on the dollar of what Gunderson or Mayo was charging for the same services. But they don't bill through insurance. That's why they can do that. So you have the opportunity as an employer, if you wanted to set up a direct contract with them. These are the services that they offer. Sorry for those of you on here. Let me switch and share their route sheet. But what we see on average is about $35 a month per employee. And that includes families. We have like 60 employers that have been working with them for a while. So we have really good data on how much is actually being used. And that average again is $35 a month per employee. You have about 80-ish full-time employees. What's the full-time? That's your total employees. What's your full-time count?
49.
Okay, so let's call it 50. Right, at $35 a month, you'd be looking at, we'll call it 24,000 for the year. That's even a little high. Right, 35 times 50 would be like 1,800 a month. So if we said 25,000 would be the budget for the year, I would put whatever money you want on that bet. That's what we see almost every single time. Some of our employers will put in a limit just to be safe, especially the first year you're doing it. You can limit employees to $500 or $1,000 for the year and how much they could eat up. But it's pretty rare that we see somebody go over that. If you look at the route sheet that we passed around, and again, I can share it on my screen. We typically, like at $38 a visit, it takes a lot of visits to get to that point. And the reality is you are a large group with courts. So your renewals are based on your claims. Courts isn't going to share us all that data with us, but that's what they're basing your renewal off of. Any claims that would happen at Neighborhood Family Clinic would not be in their claims report.
Do you include labs too? Because that's what we did at La Crosse. So like
Yeah.
labs and x-rays were covered
Yep.
through.
The thing that I recommend you exclude are two things, I guess. One is genetic testing. That can get pretty expensive pretty quick, and it's not even covered under your health insurance anyway. So that's a pretty easy exclusion. The other one is their mental health services. They have a really great mental health provider, but she bills $120 an appointment. And people who do that do it frequently. So that can just get really expensive. So we don't usually include those two services. Everything else we would include in what they can provide. And the reason we want to include it is that claim most likely would have happened on your health plan anyways. When people
The only thing I would say that's a disadvantage of Family Neighborhood Clinic is that your care isn't integrated, right? So you're not necessarily, like if you have a primary that you want to go do your like annual wellness and they're somewhere else, your records are not going to be shared. That's just one thing. It's clunky in that way.
They have improved that significantly. If you do like labs, you can actually call your doctor at Gunderson and they'll send the lab to Neighborhood Clinic and then they'll send the lab results right back to your doctor's office now.
Okay.
So they've made some big improvements and they use Quest Labs, which is actually rated higher than Gunderson and Mayo's in-house lab. And that's who they use for their overflow labs. So they don't have a leg to stand on to say it's not good enough. The real negative is when it's not employer funded is it all runs outside of insurance. So when they go there, it doesn't go towards their deductible. So if they're a high user, why would they go there? If they know they're going to meet their out-of-pocket max anyways for the year, I'd rather go to Gunderson or Vernon Memorial for everything. When you go there, we save money on those claims. A sports physical is $39. Vernon Memorial's billing you out over $500 for that visit. And it doesn't go to deductible. It's covered at 100%. So that's coming out of the city's budget. If we can pay that at $39, that's how we keep claims down, right? If somebody is really sick and has a sinus infection, when you go there, I learned this myself from my kids. We see Dr. Capelli. He was from Mayo. He's at Neighborhood Clinic. We went in for a sinus infection or strep. I couldn't tell. My kids were sick. He looked in their throat and their ears, and he looked me in the eye because he knows I do insurance. We have weird talks. Did you know that it's the same antibiotic for an ear infection or for strep throat or a sinus infection? And for children that age, we use the same antibiotic unless you have a resistance to it. So I'm not going to do a throat culture today. I'm not going to do a COVID test. I'm not going to do an influenza test. I'm going to give you the antibiotic while you're here. And I walked out with it in hand. $47 is what my employer was billed for that. They only charged for one visit, even though it was both my kids. And I was untrusting. My mom worked for Gunderson for 43 years. So I felt a little dirty about going there. I called my pediatrician, Dr. Hilt from Gunderson, and said, hey, they gave us this antibiotic and this dosage and this frequency. Is that what you would give? And she said, absolutely. What does he have? Is it ear infection or strep? Because we use that for both. Are you kidding me? They didn't need to shove that stick down my throat every time I maybe had a throat or a strep throat infection. How long was I miserable for before they would give me that antibiotic, right? And as a parent, to get in and out that fast, that's a huge benefit besides the cost savings. But if I had gone to Gunderson or Mayo for that test, they require a COVID test, an influenza test, and a strep test before they can give that antibiotic. That's $1,000. And somebody's paying for it, right? When those happen at NFC, you're going to pay less, and those claims don't hit your court's books. That's what helps keeps your renewals down in the long run. Vernon County got a negative 2% increase this year. Happened to work out that it was the same time that they had more NFC usage than ever, and they had some employees leave. Like that happens too, right? If you lose sick employees, rates go down. So I'm not shedding any veil on what actually happened there, but we see groups that do NFC as an employer contract where there's not a cost to the employees when they go there as a huge piece to reduce your costs. The negative to it is there's no way to prove those claims would have been billed to you. Right? People got deductibles to pay, right? And somebody's not on your health insurance plan might go there. So it's not going to be an exact wash that every claim at NFC would have been on your court's loss ratio. But if we're saving 80% on every one, the value is still there. And as an employer in Vernon County, you're competing with Vernon County, Monroe County, Organic Valley, Quick Trip. They all have direct contracts with Neighborhood Clinic. That employee who's been going there for free does not want to come work for you if they have to pay for their medical care now. And at $35 a month, it's a pretty low price point to be able to provide that. And the cost or the savings that we found compared to the renewal, if you decide to keep one plan, I get it, it is more work. But if you look at the savings here, even if it's only 30%, oh, did it stop sharing again? Even if only 30% moved, you're still saving $30,000. And that negative on the deductible that we're talking about, right? The $1,500 to $3,500 and losing the copays for doctor visits. If I can go for free right in town here, it's not as big of a deal. Now I'm only thinking about my out-of-pocket max. Again,
Is that $30,000 with Neighborhood Family Clinic or without, before or after it?
that's if 30% move to the HSA plan, what your savings would be.
With Neighborhood Family Clinic in there with those?
Nope. So that would pay for Neighborhood Clinic is what I'm saying.
Okay. Yeah.
And I would expect way greater than 30% migration if they don't have to have a copay or pay anything when they go there.
And their premiums are lower?
What's that?
Are their premiums are lower too? That
Yeah.
one?
Pay premiums by going to that cheaper plan. So that's going to help steer them. And then you as a city, like when you're thinking about your people and you're thinking about, do I want to move the deductible up 2,000 and even offer that? Because if someone chooses it and they get sick, they're going to be upset about it. We've solved that, right? They have the opportunity to go to Neighborhood Clinic still. And if you're worried about the full budget, we can set that limit, right? Maybe the first year we do a $500 limit just to protect you, because one person could be a lot, right? It does happen. I had a person have like 13 moles removed at a group of mine in Galesville. That claim at Gunderson would have been like $80,000 probably. But at Neighborhood, it was like $3,000. That's the highest I've ever seen of an NFC usage in a year for one employee.
So you refer to Neighborhood Family Clinic, what's the availability of these places within our region?
Viroqua is their least available.
Okay.
But when we were at Vernon County last week and I asked what's the longest anybody's ever had to take to get in, it was somebody that needed a CDL physical. There was a longer wait because it's only one physician. And then there was somebody that needed to see an orthopedic specialist and didn't want to drive to La Crosse and they had to wait 2 weeks. Otherwise, I've never heard of more than next day, if you call them.
But in terms of like, where did these places exist?
Oh, yeah, there's one right in Viroqua,
Yeah.
right over by the jail and the police station. There's one in West Salem, there's one in Sparta, there's one in La Crosse and one in Onalaska. So there's 6 locations.
And they'll do telehealth too.
Yeah, and they do telehealth.
If you have an appointment and you can't get in, sometimes they can telehealth you into like La Crosse and someone can see you.
I brought a list of their providers too. The one change is Ted Thompson is still on. Started it. He did pass away a couple weeks ago. One of their doctors is taking it over, so they're not having any changes going on, but he's still shown on this directory. But this shows all the different specialists they've added. I mean, they have multiple dermatologists, endocrinologists, pediatricians. Like, it's not just you go there for your stitches, right? There's a lot of care that they can do there for people.
So we are at 15 minutes until council. We just had the alert come up. So we'll probably have to move into a little bit of decision-making mode here.
Okay.
Can you share that screen again if you're able to?
Yep.
You should still have, from a budgeting perspective, the draft budget that has been published and it will be up for review at the public hearing is the first plan that Kyle showed, which is just the renewal of what we currently have. The HMO and the POS plans that we currently have with that on average 12.5% increase. Those numbers are what is currently in our budget. So just as a baseline for everybody to understand, we can afford that. We have planned to afford it. What I like about what I'm hearing here, and I'll just skip to my position on it, is I think offering options is always good. I hear a little bit of what Lori's saying from an administrative feasibility. There's some concerns there, but being able to offer people different options and say you could go to this plan or you could go to that plan, and it kind of however they doctor or whatever they foresee their medical needs are and their financial needs, they can kind of shift accordingly. I'll take a pause there, and then I have a question about the neighborhood family clinic in addition from a budgetary standpoint.
My concern isn't the fact that it's extra work. My concern is if they take a separate HSA plan, how it works with the HRA, because we're supposed to allow it for everybody who has those plans. So how that's written is where the confusion's coming in on my part, because is not everybody going to be available to have the HRA, or is it just going to be those that take their current plan? Or is it going to be those that have the HSA plan? All of that, I guess, needs to be vetted out. And to know that by next week is what I'm concerned about if we do offer more than one plan.
So we have many groups that do it that way, where the HRA is only tied to one of the two plans. It's not like you're not making it so people can't buy that plan, right? If you said only certain people can buy the copay plan, then it would be discriminatory. But you're allowed to offer two plans as long as everybody has access to those two plans. They don't have to be identical. And we've already, because we've done it so much, we would make it as easy as we can for you.
Right. I just want to make sure that we're not discriminating one way or the other, because we have to present it to both. But if you wrote the plan that the HSA does not have access to the HRA, then I can understand that would flow together. And then I guess the other point would be, if you guys are interested in the neighborhood clinic, how would that just be with that second plan that you were showing, and it wouldn't be available to the other one, correct?
No, with the budget we were just talking about is making it for everybody, whether they're on health insurance or not, which is a huge benefit when you're trying to retain people and attract them.
So that's to every employee, no matter if they're on health insurance or not? How does that be affected then if we're paying people not to take an insurance?
It would be all full-time employees.
Yeah, I mean, we'd have to have a conversation about if there's an opt-out agreement and things like that. I mean, people receive a stipend for opting out of health insurance if they go with a qualified plan on a significant others, or whatever it may be. Would those people have access to the neighborhood family clinic, or would they be, they would have
So you can set up exclusions, where it's only people that are on your health plan, but then they're not eligible for their HSA contribution if they want to do it on their own, because they have first dollar benefits. So if it's tied to your health plan enrollment, it violates the HSA rules. If it's not tied to your enrollment, then it doesn't affect that. And I would hate to see you offer this great benefit to 90% of your employees and have that 10% not get access to it for what the extra cost.
Well, we're at about 33% of people opt out. Good questions. Neighborhood family clinic, the risk there from a budgetary standpoint is we offer it and not enough people move over to the HSA plan. Right? Like that's a real potential where everybody says, well, if I have the HMO, I have co-pays, but what's even better than co-pays is going to the neighborhood family clinic. But then We'll probably be pretty close then in terms of interest. Yeah, this is where it gets a little bit challenging is to identify financial risk for the city.
Absolutely.
Um,
I would assume, I mean, again, I'm just coming off of numbers I've seen other groups, but every group is different. So it's tough. That's why I went with 60-40 when I
Yeah.
floated it
Is the
first.
neighborhood clinic something that has to be decided now, or can it be picked up later?
Yeah.
After we know what the enrollment is?
Yep, you could pick it up later. But again, that's what's gonna help steer a higher percentage to the HSA. But we have a lot of groups who do two plans without doing neighborhood clinic. That is perfectly acceptable. And we'll still talk about neighborhood clinic and educate them on, it's only $39 when you go there for a visit versus your copay on your health plan. Like they're still paying something on the copay plan when they go. And it takes longer to get in. Like we'll still educate and people will go there more, but it's not the same as being free. And there's not a lot that you can do for $35 a month that's that impactful to your employees.
Quick question. Are the employees happy with the insurance plan they got now? I don't know how many people are on it,
we
but
haven't polled,
okay.
we haven't surveyed. It'd be a good survey question, but I would say that I've received less complaints than when we were on Exemplar. I do know that the drop in the city's contribution towards their health insurance premiums was not, as you would imagine, was not favorable. And just the rising cost of health insurance is hard for people to eat. And for those reasons, just giving people different options within the city's plan instead of two, I think is a good idea. The neighborhood family clinic, I have not run any numbers on that. I would like to get more comfortable with that before I would say, let's move towards that. But I get what you're saying. If the HSA plan out there and the carrot to go that direction is like the neighborhood family clinic exists, but people don't know that by the time open enrollment period ends, it's going to limit their desire. But I think we just have to, at this point, be comfortable with taking steps towards an optimal plan over the course of 2 years instead of trying to hit it dead right on year one with the insurance center.
I would agree with that, Nate. I would say with I have courts now and I have like the top tier one or whatever. I would say as far as simplicity goes, the courts plan is much simpler because you don't have all these other things you're navigating. But I think it would be better to get a sense of what employees want first before switching over to something if it's in budget. Because there's just gonna have to be so much onboarding and support for it and more work for Lori probably.
I still think offering that HSA right now, I don't see a downside to it because if anything, again, we budgeted for everybody to stay with the HMO, which is the highest plan, and the POS, which is the highest plan. We've already budgeted for that. We can cover that. Offering the HSA offers us and the employees an opportunity for lower premiums at the cost of higher deductibles and no copays, but at least to give everybody the option, and we'll see what happens. And then meanwhile, this year we can work on what a contract with the neighborhood family clinic looks like, especially when we start talking about per employee limits and how that may impact with opt-out agreements. Like all that is very interesting information, but it's just going to take time for us to wade through. So
I get it.
that's where I'm at with it right now. Lori, I don't know if you have another perspective as sort of the health insurance guru in-house at least.
I feel much better in a phased-in approach than trying to throw everything in a bag and then try and figure out what we want to pull out later. I think it's the best option at this point.
And I think one thing to think about being fully insured with courts, right? Everyone's paying into this bucket, even with the HSA. Whatever that loss ratio is what courts determine that's a renewal every year. So to simplify things in the future and actually get a better control of your budget would be turning on clinic, because then those claims never ever hit that bucket and courts never knows what people doctored for, and it's free for employees.
It stabilizes the rate of inflation on our health insurance, right?
That's what I'm saying. That's the long-term goal.
Yeah,
So
yeah. I mean, certainly we want to look at it. It makes a lot of sense. So
Doesn't have to be this year. And I'm not trying to push things on you, right? I'm just trying to show you the rocks oh, sorry. Yeah, dang it. Yeah, not trying to push it on you, right? I just want you to see how it works and how we make room and budget for it. So it's not a new cost to you, right? We saw the renewal price. This is what we could do with some savings. Doesn't have to be a right now thing. We could keep things as is and have a more, a longer runway for next year to make plans. But I want to make sure that we're bringing you your different options.
but to your point, Lori, your life simpler too, from an administration
Thank
point.
you,
We-
because this is not what I'm hearing.
Yes, we do want to make it simpler for you.
Tanya, you had something?
Yeah, I realize we're not gonna, this isn't going on to council tonight, so we still have time to get some questions
You gotta
answered,
go
but
now.
We got to go
Okay.
now because we got
I
open
can
enrollment
ask
next week.
questions. Okay. It was not clear to me how much the neighborhood clinic is gonna cost the city, and can you just clarify, because it's been a while? The city pays for a portion of the premiums for our full-time employees. Is that
Correct.
correct?
Yep.
And whatever that number is, we already
85.
decided. It's what?
85.
85%. Okay, so the cost to the city is 85% of what the possibly lower premiums are, and then what's the cost of the neighbor, and the city pays this 100%.
The neighborhood
If we
family
did that.
clinic is an idea that is not, I don't have, I would say at this point, we do not have a proposal
Okay.
tonight for going to the neighborhood family clinic because we have not run any numbers or decided on limits or run forecasts on usage, anything like that. So that's why I said that's a great idea, opens up options
don't
in the
need to worry
future,
about it
but
right
not
now.
something we can act on now. Simply what it was, or Kyle, I know you put your computer away. It's offering the HMO, the POS, and then opportunities for an HSA version of both.
Great,
Right?
thank you.
And that, no matter which way people choose, will retain within budget, so long as the enrollment numbers that I have in my budget hold steady. Right? If a bunch of more people add on who weren't on insurance at all, obviously that's going to change dynamics, and we're prepared for that to a degree. But offering an HSA at this point just opens up more options for people.
Just to say it, United Healthcare's in here, they cost more and their plans are worse. So I don't think we need to go down that.
So with that, the option that, again, I'll just iterate that we'll need finance to take action on tonight is to move forward either with the same plan that we've always had, which is an HMO and a POS plan with copays essentially, or to expand that option by also having an HSA version of that has no copays, which means, but no family clinic on the table at this point. Is that?
Mhm.
Okay.
Yep. Yep, absolutely. And I think in doing that, even if you have minimal migration, and even if it's 20%, that's all just savings below what you were budgeting for. And then hopefully we can earmark that for neighborhood clinic in the future.
Neighborhood family, yeah.
So yeah, we'll need a motion on the health insurance options for 2026.
I'll move that we go with the new option of 2 or 3 new plans. Is it 2 or 3? 3 new plans?
It'd be 3 total.
3 new plans?
Technically, it's 4.
4.
What's the fourth?
Because it would be HMO and POS of the copay and HMO and POS of the HSA.
Oh,
plan.
so there's the POS version of that as well?
Yep.
Okay, gotcha.
You could decide to not offer that if you want, if you want to do 3, but
No, I just wanted to clarify because I didn't hear that was another option, so.
The motion is to approve going with the 4 plan option this year.
This is John, I'll second.
Okay, we have a motion and a second. Roll call.
John,
Aye.
Emma?
Aye.
Todd Kirking,
Aye.
Tanya,
Aye.
Todd Spath.
Aye. Okay. Motion passes.
Todd, for the sake of time, I think we could probably skip admin updates and just go right to bills. Is that okay with you, Lori? Or you guys can decide what to do, but
Yeah, I think you're right. Yeah, we'll just go right to the payment of the bills then.
we'll provide an admin update.
Yep.
Next time around.
here's
Okay.
the turn-offs.
Okay, in the original bills, I just wanted to point out that we're paying the 3rd quarter mobile home fees and the 3rd quarter room tax. Room tax has been outstanding at $30,423.95 going out. That's like two quarters in a row now that are going out the door.
And just to note, that's the 70% of what we owe the tourism. So the actual room tax is a heap on top of that as well, right? So.
Correct. On the last page of the original bills, I just wanted to point out the $250 at the top. Originally, we're trying to clean up some of the the checks that haven't been cashed, and originally it was made out to the Onalaska Legion. However, the Viroqua Legion Baseball paid them, and so we're just reimbursing the Legion Baseball. So it's not any new money that's going out, it's just to a different carrier. And to clean that up,
It was page 6, right, Lori?
page 6, correct. Then also on that page, there's the second reimbursement to the utility for the Center Avenue project. If you remember at the last meeting, they're paying all of the bills and we're paying our portion of it back to the utility. So that 99, 621, 77 and 58, 46, 31 is going back to the utility. And then we also have the TID 7 Railroad Avenue for Veerbecker for $9,100. And everything in the additional bills is pretty much utilities and just normal monthly bills. So nothing really to point out on that. So
Okay, I don't have any questions. Anybody else have questions?
I'll make a motion to pay the bills.
Second.
Okay, we have a motion and a second to pay the bills. Roll call again.
okay, Emma,
Aye.
Todd Kirking,
Aye.
Tanya.
Aye.
Todd Spade
All right.
and John.
Okay, and then we'll not do agenda item 6, the administrative updates, and second period for public comment, I guess. Nobody?
I think you're good, Todd.
Okay. Adjournment.
Start to make a motion to adjourn.
Second.
Okay, all in favor?
Aye.
All right, we are adjourned.
Thanks, Emma. See you shortly.